Hello, my name is Dr. Phil Boyle from Dublin, Ireland, and I am happy to present to you a presentation about new treatment for premenstrual syndrome and premenstrual dysphoric disorder through endorphin stimulation. I've been doing this in clinical practice for about 20 years, and I'm happy to share the insights I've gained from my clinical experience. I do have some conflicts of interest. I am the co-owner and developer of the Neo-Fertility Charting Method, and I'm also the co-owner and developer of the Chart Neo-Fertility app, which I'll be advising to use throughout the presentation as a very reliable way of documenting and monitoring premenstrual symptoms. So the outline for my talk. First, I would like to outline what is premenstrual syndrome and its close relative premenstrual dysphoric disorder. I will go through how we make the diagnosis in clinical practice, and then I'll explain the hypothesis: are low endorphins associated with premenstrual syndrome? We'll look at a previous clinical trial using naltrexone treatment to treat premenstrual syndrome, and I'll outline a strategy for a new trial using naltrexone at 3 milligrams to treat premenstrual syndrome, which will be a superior strategy. I'll go through 2 case reports from patients that I'm currently treating, and then we have the references at the end. Premenstrual syndrome is when women have cyclical bloating, breast tenderness, and mood changes. These symptoms typically occur for 4 or more days prior to the onset of menstruation. So 1 to 2 weeks before the menstrual bleed begins, women would report a collection of unpleasant symptoms. A really important component that we require is that during the menstrual flow, the woman experiences relief of these negative symptoms. And another important factor is that if the symptoms are severe enough to impact daily activities and functioning, then it is a problem. It is argued that many women have premenstrual syndrome, in fact the majority, but when you implement these criteria, you'll find that it's somewhere between 3 to 8% would actually meet these criteria. So we like to ask, what symptoms in particular do you have? How many days do these symptoms last for? And how severe would you rate the symptoms out of 10? So in clinical practice, I judge this very quickly and say, in the week before the period begins, how many days of symptoms have you got and how severe would you rate them out of 10? So very quickly I get a summary of the whole cluster of negative symptoms, and I get an idea what the problem is. Premenstrual dysphoric disorder is a more severe condition, and it's listed in the DSM-5, that's the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. It's listed as a separate entity under depressive disorders. In the United States, the DSM serves as the principal authority for psychiatric diagnoses. So PMDD is a psychiatric diagnosis. It's not easy to diagnose. There are lots of criteria required to definitively prove that somebody has premenstrual dysphoric disorder. A woman would require to have at least 5 of the following 11 listed symptoms, and it must include at least 1 of the first 4 listed symptoms that are present in blue. So those 4 are primarily mood related, so a low mood, hopelessness, followed by anxiety, tension, teariness, persistent or marked anger and irritability. So at least 1 of those things must be present, combined with any of the remainder of the symptoms listed. So it's a lot of symptoms to try and get your head around, to ask, well, are these symptoms present or not? Physical symptoms I find are important as well, such as bloating and breast tenderness. But women may also complain of swelling, headaches, joint and muscle pain, as well as weight gain. In addition to those criteria listed, it must affect social, occupational, sexual, or scholastic functioning. The symptoms must be directly related to the menstrual cycle, where there is a variation becoming severe, especially in those 2 weeks before menstruation, with relief during the menstrual flow. And something that makes this more challenging is that these criteria need to be confirmed by prospective daily ratings. So what that means is you can't ask a woman after the event, what was it like last week or last month? She has to record it on a day-by-day basis, and that's what prospective daily recording means. And she must have these symptoms for at least 2 consecutive symptomatic menstrual cycles to say that it is premenstrual dysphoric disorder. It does change from cycle to cycle, so they will accept if you have it for 2 out of 3 cycles, that would also be acceptable. So like I mentioned earlier, it can affect between, whether it's premenstrual syndrome or PMDD, it affects between 3 to 8% of all women. And officially, there's no official exact cause known for this condition. I will put forward a hypothesis of what seems a very reasonable explanation for how it happens. There are proven risk factors, so if there's a history of past traumatic events, if you are obese and if you're smoking, then these are risk factors that will make the condition worse. And it can run in families like any kind of medical condition. So our current diagnosis in clinical practice is based on history. We go through retrospective recall, where somebody presents to the practice, documents their symptoms, we record that, and then we engage in prospective data collection. And in particular, the ChartNeo app, which we use as a fertility assessment, we also document the DSM criteria through our app. We can document 17 different symptoms that the woman can choose which ones are most problematic for her, and she can rate the severity out of a scale of 1 to 10. Excuse me, how severe does she find those symptoms? So this is what it's straight out of one of our patient records, and our question is, do you have symptoms of endorphin deficiency? 1 means there's no problem at all, 10 means you've got a severe problem. So we ask generally throughout the cycle, and this is not related specifically to premenstrual symptoms. Do you suffer from generalized fatigue? How bad is that out of 10? Do you have low mood generally throughout the month? How bad is that out of 10? Anxiety and difficulty sleeping. And then after that, we're interested in the premenstrual symptoms, and I've listed a number of the typical symptoms here, and we ask a woman to document how many days are these symptoms present for, and how severe do you rate these symptoms out of 10. And that gives me a very quick summary as to how bad she experiences the premenstrual syndrome. It's enough to get started with, because then when they start to document with our app, we document the data in a prospective fashion, which I'll demonstrate shortly. Another interesting thing that I like to ask is if there's any family history of autoimmunity. For this particular patient, there was no history of autoimmunity. She had low levels of problematic symptoms such as fatigue, low mood and anxiety, and 1 day of premenstrual symptoms. So this is somebody clinically that she does not appear to have clinical endorphin deficiency. The Validated Menstrual Distress Questionnaire is the official recognized way to identify and prospectively record symptoms. This is a validated questionnaire, which means that it's been shown through published studies to be a reliable means of documenting the presence or absence of these symptoms to identify either premenstrual syndrome, or it's essential to confirm premenstrual dysphoric disorder. There are many symptoms listed here, more than the 11 on the DSM list, and you can actually bunch them together to get the 11 that are on the official DSM-5 diagnostic criteria. So what we've done through our app is we ask these bunched questions together, and we are able to document which symptoms are most problematic. But this is what it looks like on paper. So there's a bunching of symptoms to meet the DSM-5 criteria. On our app, it looks like this, and simply depending on what day of the cycle the woman is on. So this is showing the 1st of August, Monday the 1st of August, she was on day 22 of her cycle. The number 9 means she was 9 days after ovulation, and she was able to document that swing there is for mood swings, and then we have fatigue, low mood, irritability, bloating, and so on. And she simply just taps how far along the scale she feels she is, from no symptoms on the left to severe symptoms on the right. And then this is prospective data collection. She records it during the day, or any time during that day. She documents these symptoms, how many symptoms are present and how severe does she feel them. And we correlate it with the stage she's at in her menstrual cycle, which is a key important factor as well. This is what a typical menstrual cycle would look like, and the first example is a 27-day cycle with ovulation identified on day 14, and that's a normal, healthy looking menstrual cycle from a fertility charting point of view. The second line shows ovulation occurring on day 9, and the third line shows ovulation occurring on day 23. And with regard to the timing of ovulation, it moves around quite a bit. So if you don't have a means of documenting what stage of the cycle the woman is at and where is she ovulating, it's more difficult to get meaningful data from a menstrual distress questionnaire if ovulation time is not clear. So that's where documenting with a fertility app like this really helps for getting relevant information from the menstrual distress questionnaire as well. But the handy thing is that questionnaire is integrated to the app, and it makes it easy for the woman to record and get all the information we need. This is what our app looks like, and a documentation of the premenstrual symptoms. And to orientate you, day 1 is the first day of the menstrual bleed. This woman appeared to ovulate on day 14, the last day of observable cervical mucus. In tandem with that, she had a temperature surge to validate and confirm that yes, that's where ovulation occurred, and she had a 13-day luteal phase in total for a 27-day cycle. She was recording her symptoms, and as she records her symptoms, if you hover over what would we call it, the symbol here, then we can see that that symbol is for bloating. She rated it a 7 out of 10. The one below that, it's for breast tenderness, and the one below that, we can see low mood. So either the patient or the doctor that she shares the information with can go into the web portal to observe what's been recorded on the app. We can observe it through the intranet once she has confidentially shared her data. And with this example, she has a cluster of about it's 9 days of symptoms. She's got significant severity. She has the ability to write under her notes how much it's impacting with her ability to function socially or otherwise. And we get a very good record of how bad the symptoms are. With the onset of the menstrual bleed on the next cycle, she can document if there's relief of these symptoms during the menstrual flow. So for a proper diagnosis of either PMS or PMDD, we should see that the number and severity of symptoms is less on a non-treated cycle before we implement a treatment strategy. So in this case, it does not meet the criteria for premenstrual dysphoric disorder because she's only documented 4 symptoms. We need 5 symptoms documented. Also, she needs to document the social functioning and the impact on her ability to work or function socially. So that isn't documented here either. So this would be in the category of premenstrual syndrome, although possibly with more precise documentation, she could meet the criteria for PMDD. But regardless of what exact terminology we apply to this, we can all agree this is providing these symptoms are causing a significant degree of distress and dysfunction for the woman who has it. So our next section, what about the underlying cause, and what about the connection between possible low endorphins and premenstrual syndrome? Well, way back in 1987, the Journal of Fertility and Sterility published a study where they evaluated 19 patients. They had 11 who had premenstrual syndrome, and they had 8 controls without premenstrual syndrome. During the study, they measured, and I have the reference at the end of this presentation, but during the study, they measured beta endorphin levels every 2 to 3 days from mid-cycle until right through into the beginning of the next cycle. At the same time, they used the menstrual distress questionnaire to document the unpleasant symptoms that were present throughout the cycle. Premenstrual syndrome patients showed a decrease of plasma beta endorphin levels in the week preceding menses. The beta endorphin values of PMS patients regained normal levels during the next follicular phase. So this would be a viable hypothesis to say that when endorphin levels drop, you feel these unpleasant symptoms appear, and then with the restoration of endorphins, the negative symptoms return to normal. And another important thing with our control group, there were no changes of the beta endorphin levels in the asymptomatic women in the control group. So it's a strong hypothesis to explain the drop of endorphins is associated with premenstrual symptoms. The menstrual distress questionnaires revealed that premenstrual symptoms, that women with PMS complained of water retention, pain, discomfort, and mood swings as the top 3 negative symptoms. And here's a copy of the graph from 11 days prior to the onset of menstruation until day 7 of the subsequent cycle. And you can see that very obvious dip in endorphin levels documented from days -5, -2, and the day before the onset of menstruation, a significant dip, and the p-value is greater than 0.05, indicating that despite the small numbers in this study, that dip did not occur by chance, that it achieved statistical significance. The dotted line above that indicates the endorphin values for the control group who did not have premenstrual syndrome. So it's a very plausible hypothesis that endorphin deficiency and a dip of beta endorphins in the week prior to the onset of menstruation provides a possible explanation for these unpleasant symptoms. There was another study, as I was looking through the published articles, and this was in 2002, and they looked at 27 women with full premenstrual dysphoric disorder compared to 27 healthy controls. And those with premenstrual dysphoric disorder had greater pain intensity and lower beta endorphin levels in the luteal phase compared to the symptom-free controls. And again, these results suggest that endogenous opioids may be pathophysiologically relevant to premenstrual dysphoric disorder. So a clinical trial back in 1988 attempted to treat those low endorphins to try and correct premenstrual symptoms. This was conducted through the Mayo Clinic, and it was by Chuang, CJ, and colleagues, and it was a clinical trial of Naltrexone to treat premenstrual syndrome. It was a double-blind, placebo-controlled crossover study. So the idea of this is that the women and the researchers did not know what was being taken, whether it was active medication or inactive placebo at the different stages of the study. And after 3 cycles, they changed over and they got the other medication. So at one point, so they were their own controls, is how the study was designed. So that's your crossover study. The hypothesis was if we could prevent a drop of endorphins, that the premenstrual symptoms should improve. So that's the idea based on the study from a year earlier. Let's see if we can prevent that endorphin drop by giving naltrexone. Now, at that time, they had 16 subjects who received either, they took on 20 to start off, but only 16 completed the study, and they received either placebo or naltrexone at a dose of 25 milligrams twice daily for 10 days, from days 9 to 18 of the cycle. For 3 consecutive cycles. It was hoped that the 10 days of opioid inhibition through naltrexone would cause a rebound surge of endorphins, correct the endorphin deficiency, and provide relief of premenstrual symptoms. So that was the hypothesis. It was a hope that temporarily blocking endorphins would cause this rebound surge and correct that deficiency. The results after the crossover study was completed, the menstrual distress questionnaire on day 25 was 10 points lower, indicating an improvement of premenstrual symptoms for 11 out of the 16 patients. But 2 out of the 16 patients, it was 10 points higher, and it seemed to make matters worse. The conclusion of the study was that correction of low endorphins with naltrexone 25 milligrams twice a day may help in treating premenstrual syndrome, because the majority from the study did get some relief, and it showed that maybe this could be of benefit. But it was only mild improvement in premenstrual symptoms, and it was limited usefulness because there were some side effects from the naltrexone that was used. So the question is, and it's an obvious answer for most people attending a conference on low-dose naltrexone, but the question is there a better way to prove low beta endorphin levels? And I think most people here know the answer to that. And from the work of Dr. Bernard Bahari, he found that by giving a low dose of naltrexone, less than 1/10 of the licensed dose, giving an amount ranging from 3 to 4.5 milligrams, if you just take this at night, that he has shown from his work that you get a 3 to 4-fold increase in beta endorphin levels. You get a very significant surge of endorphins with this low dose naltrexone. So it is likely this would give a superior surge of endorphins compared to the strategy of naltrexone 25 milligrams twice daily for 10 days from days 9 to 18 of the cycle. So our proposal is, let's do a new clinical trial using a very similar design to what the Mayo Clinic did. We would double-blind it, we would make it placebo-controlled and a crossover study. But instead of the way they had used naltrexone, we would use naltrexone 3 milligrams nightly right throughout the cycle. So that is in process, and trying to get a clinical trial completed is much more difficult than you would imagine. And when we come to the point of looking for ethical approval for our study, we've encountered difficulties there in the first place, and the concern being that we're using a new drug completely. Bear in mind, naltrexone is a licensed drug, and it's gone through all the safety checks and balances, and we're just using it at a lower dose, and it's a repurposed use of it, using it for something outside of the product license. But because the dose is so low, we've encountered some difficulties that the Ethics Review Board is saying that this should come under a drug trial, like a new drug, and it's made life quite difficult for us. So we've got all kinds of difficulties to overcome there, and we have not yet got to the point of commencing the study, but we're hoping we'll find a way to do that. So our plan is that we would document the premenstrual symptoms with our validated menstrual distress questionnaire criteria, and we would have prospective documentation of this data collected through our Chart Neo app. Some patients we will then discover have just premenstrual syndrome, and some will have PMDD, because it is a prospective diagnosis, and so we will have a mixture. It won't be all PMDD. If you are a doctor and you wish to participate in this prospective clinical trial, please contact me. My contact details will be available at the end of this presentation. Now, let's look at two case reports. So this is somebody who's currently attending my practice. So I run a fertility clinic, and most patients who attend my practice, their primary concern is not their premenstrual syndrome, it's primarily their fertility. And this is the form that I showed you earlier. And for this particular patient with the ID number listed there, she does fit the criteria for endorphin deficiency. Throughout the entire cycle, she complains of low mood, anxiety, and fatigue. And specifically in the 4 or more days prior to the onset of menstruation, she has 5 days of multiple symptoms, average severity rated as 6 out of 10. And so she says that exactly 5 days before the period begins, that her mood plummets like a depression, and she feels like a 9 on that particular day, and then her low mood and other symptoms are as indicated. So she does have significant discomfort from that. She's a 40-year-old school teacher, has been trying to conceive for 2 years. What's interesting from the published data on premenstrual syndrome, that it doesn't seem to be connected with impaired fertility. Our clinical experience through my practice would certainly be different in that regard, and we would find that as we improve the premenstrual symptoms, we get better pregnancy outcomes as well. Typical dose of naltrexone for us is 4.5 milligrams. Usually we start with 3 milligrams for the first week, and then we go for 4.5 milligrams thereafter. I'm aware that some people start with even lower doses, but in practice, this works well for us. And it seems that we're going to get the vivid dreams, sleep disturbance very commonly for 5 to 7 days, whether we start with 2 or 3 milligrams. So I just start with the 3 milligrams, and then I put it up to 4.5. And for the majority, that's the dose we would need. There are some, we go back down to 3 milligrams as the maintenance dose. And if somebody is very light, if they're and I think 3 milligrams is better, then I would go for that dose instead. To confuse the picture a little bit, we don't just do naltrexone. We've got multiple interventions recommended at the same time, and the dietary strategy really does help as well. So a difficulty for our study design will be having a single intervention and resisting multiple interventions concurrently, such as supplements and dietary changes, because they help with general health as well as fertility and premenstrual syndrome. But in any case, that's part of the challenge to cover that. But that's what we do. Change the diet, go on these supplements, take your low-dose naltrexone. So for this woman, her review after 2 months, she said that her premenstrual symptoms had greatly improved. And to be honest, that's all I documented on my file, because I see it quite commonly, and I just say, great, that's heading the right direction. Now let's focus on your fertility. But I had a review with her just a few days ago, and I got her to quantify with numbers her symptoms. So she said that her symptoms had dropped down to 2 days, and the severity on average was 3 out of 10. So significant relief from her negative symptoms. This helps to see a picture view of it, where before she took the low-dose naltrexone, she had lots of symptoms documented, and after she took the naltrexone, there were far fewer symptoms documented. Now, she did admit that she wasn't as interested in recording every one of her symptoms, so it may not be a completely accurate picture, but it wasn't enough of a problem for her to even bother recording it. So to me, that tells its own story. The next case of premenstrual, and by the way, we're still hoping that she's going to achieve success, but we're doing other things with regard to her fertility, which is beyond the scope of this current presentation. The next case, the number is listed there. She also was for a review last week, so I was able to get exact numbers from her, but her situation seems more severe. She had more profound negative symptoms such as fatigue, low mood, and anxiety, and she scored 7 out of 10 for her symptoms, or 7 days of symptoms, and 9 out of 10 severity. So this is very much more in the PMDD region. She's age 43, trying to conceive for 5 years, and we started her on the Naltrexone, our diet, and our supplements. And at review, 5 months later, she said her premenstrual symptoms had greatly improved. And just last week, when I saw her in person, I got her to quantify that. She said she's down to 3 days, having previously been 7 days. And the severity is still a bit there. It's 5 out of 10 for those 3 days, but it's a big improvement compared to where she had been. And she says her ability to function is now much more normal. And those 3 days when the symptoms are there, it doesn't impact her ability to function like it used to. So without being able to measure endorphin levels, I am recommending endorphin stimulation in clinical practice, and this is something I've observed in clinical practice for 20 years. From that, I'm confident that our study will prove that low-dose naltrexone is effective, but until you go through the study and document it in a systematic, methodical way, apart from clinical experience, definitive scientific studies and proof is still lacking. What was also very interesting for this patient was that she said, but also my psoriasis is much improved and my ankle swelling is better. So as part of our questionnaire, we do ask about autoimmune conditions as well. And it's a thing we do see with our immune modifying treatment with low-dose naltrexone, that you'll find a range of autoimmune conditions tend to get better. So that's another positive. And for me, that's a strong clinical indicator that we would give her the best chance we can for her age. And at 43, it's always more challenging to get success. Yes, we have had success with couples in this age group, but the percentages get tighter, certainly from 43 plus. So our goal is we'll make the conditions as good as we can. And part of that is by boosting her endorphins if she's clinically endorphin deficient. So the overall strategy with restorative reproductive medicine, which is what I do, is that as your general health improves, so too does your fertility. So the goal is get your health right, and then let's work on your hormones and your fertility cycle. And naltrexone is a big part of that equation. So these are the references, and which will be available to you afterwards, that I've referred to as throughout the presentation. So, and I've got them all listed there. And finally, these are our contact details with my website and our app at chartneo.com. So thank you for attending this presentation, and I hope you find it of benefit. Bye for now.